Hi, I'm Dr. Jack West, medical oncologist at City of Hope Comprehensive Cancer Center in Los Angeles. This is West Wind, a podcast focusing on the intersection of cancer care, emerging technology issues in medicine, and healthcare policy. You can find information about subscribing at beaconmedic.com or wherever you find your podcast content. Please leave a review, especially if you like this, and we'd also love to get your feedback at westwindpodcast@gmail.com. I'm happy to be here today with Dr. Matthew Gubens, who is an associate professor in medical oncology at the University of California, San Francisco, and he is particularly a lung cancer specialist. So thanks for joining.
Thanks for having me, Jack. Always good to see you.
Let's just start with a basic question of what led you into lung cancer. Was it a booming field when you entered it, or was it a little before that when the options were quite limited?
Well, like lots of things in life, serendipity plays a role, right? Start fellowship, and I had just a tremendous mentor, Heather Wakely out of Stanford. And she was one of the junior faculty who was excited to work with the new medical students, the new fellows. And, when I was starting fellowship, that was when Alimta came to be, pemetrexed. That was the exciting thing on the horizon. But we had this inkling that the targeted therapies were coming. And it really it was the opportune time to start as a fellow and to have opportunities. And of course, it's exploded since then. So I'm forever indebted to Heather Wakely, who let me into her clinic, first as a med student, then as a fellow. And it just kind of ballooned from there.
Mm-hmm. So you're now at UCSF, and it must be interesting. You're working in the Bay Area where there are multiple centers of excellence. You've got Stanford, you've got UC Davis, and of course UCSF with a great reputation. Is it competitive? Is it difficult, or is it collaborative?
I'd say it's a really interesting dynamic. I mean, among the investigators, we're all friends, we're all colleagues. Dr. Gandara was a mentor to Dr. Wakely. Dr. Wakely was a mentor to me, to John Reese at Davis. So we're kind of all close. We're all on text paging. And, the patients in the Bay Area are so savvy. They listen to the Jack West podcasts, and they kind of know what they're looking for. And there definitely are that set of patients who do what we call the trifecta. They go to all three of us and go to every three of us Q2 months. But then we also have a really neat patient population where folks come from the Central Valley who really are not as medically savvy, but they just have an inkling that they want to go somewhere to get a second opinion. So It's a really neat case mix. But I think in terms of the research, knowing that we're these strong research institutions, yet none of us huge, we kind of say that we try to open different trials, we try to collaborate so that kind of collectively the Bay Area can compete with the likes of an MD Anderson or MSKCC, if you will.
So you do coordinate things that you wouldn't all have a trial for a rare mutation, but rather say, okay, well, we'll have one for HER2 and you can have one for RET fusion.
To some extent, yeah, exactly. So I think that's and it's good for the patients and good for us. It's not useful to cannibalize each other. So I think, it's somewhat informal, that arrangement, but I think it's worked well for all of us.
Okay.
And we kind of are just far enough apart that the catchment areas really don't quite overlap. Someone who lives near Davis kind of has to make an effort to get to Stanford and to UCSF. But the really motivated ones do.
UC Davis has developed some telemedicine, at least looking out into the more rural areas, Central California. Do you have any idea of how that's working? Have you guys talked about anything like that to reach the broader range? Because certainly UCSF is in the midst of a very crowded area where traffic can be prohibitive, even if people are in within the close area.
Well, a couple answers to that. First of all, certainly the business development side of UCSF is concerned that it's a tough market. And even aside from the other academic medical centers, you've got Kaiser, you've got Sutter. And so how do you kind of build the market share for us? And so they're talking about having these kind of branch kind of practices that we're affiliated with in some kind of confederacy sort of sense, not quite acquiring outright the way Stanford has or the way Davis has. So it's kind of a work in progress, if you will, though I'd say it's driven more by business than by oncology care excellence. I think, though, to your other question, we definitely have been doing more telemedicine. We've started kind of adopting the Zoom platform, and we were open to video visits, and I know that our medical center has been aggressive with the insurers to kind of get reimbursement for those. And I found it's really useful, especially, again, my patients from the Central Valley, if I can kind of do 95% of what I would do in a normal visit, by video visit, everyone is helped by that. And I'm glad the insurers are starting to recognize that, at least in a pilot.
What does that look like for you? Is that just having a day where you'll have a live visit followed by a televisit, or do you have a half day or some other fraction of time that is just dedicated for virtual online visits?
We've actually scheduled them into our regular clinic day. So at the 8 o'clock appointment, I have the live person who's getting chemo upstairs. At 8:30, I have the televisit from the patient who's 400 miles away, just kind of calling in to review results and talk about what to do next.
When you do have patients who are a long distance away, are you the oncologist, or are you partnering with someone who may be a more general oncologist who is further out there, and you're part of a team and you're offering the thoracic oncology expertise, but expecting that they're going to manage and administer that locally?
Generally, it's the latter, and I think that's been a nice relationship with some of these super busy general oncologists who the patient's motivated enough to want the second opinion, and the medical oncologist there is happy to have some interaction. So generally, that's been the MO.
Yeah, I've been speculating that it must be incredibly hard to be a general oncologist these days when, I have had a focus on thoracic and GU oncology, and frankly, it's hard to keep up with both of those to the extent that they've exploded, which is a great problem to have. There's so much going on, so many advances, but to be treating 12 or 15 kinds of cancer in a day, and even imagine keeping up with that.
I have the utmost of respect for general medical oncologists these days. I'm not sure I could do it, to be honest. So and I really take my hat off, and how busy they are and how much they have to assimilate information-wise. It's hard enough to be the thoracic specialist because I feel like there's a fountain of stuff or fire hose of stuff plumbing coming out at us.
But then, by the same token, I would imagine that many don't feel a threat of you offering a suggested plan as if that's taking away anything from them, because you can't be all things to all people. It's just a fundamentally different role, and to be able to be the one caring directly for the patient and with the strong relationship with them is not a lesser role at all.
Exactly. Yeah. Exactly.
So, do you have any specific collaborations with tech folks? I mean, with Google and so many other big companies in the area, are they looking to you to pilot certain things that are AI or anything like that, or are you really operating independently?
I would say that just based on our locale and the interest in the Bay Area, that we do have a fair bit of academic interest in kind of plumbing the databases of big data. And so I think that we have a couple of great faculty members who that really is their charge, to say, how can we take the medical information, not even just from UCSF, but pan-UC, which all has Epic, all has a way to integrate those data, and how can we use big data techniques to do meaningful research? And a lot of that is in collaboration with, or even, I believe that one of the faculty members even has an endowed chair that's kind of funded by one of the tech companies. So it's kind of been, it's interesting. But I would say that we still mostly go it alone.
Yeah, that's fine. Now, we just got a little news this week about an abstract being presented at the AACR meeting in April, and all we have is the abstract about liquid biopsies or blood-based NGS testing from Guardant that reports that the sensitivity is good enough that essentially the detection rate is every bit what was seen with tissue, in fact, numerically even a little higher. So can you speak to how much or how little you're using blood-based testing for initial diagnosis, and whether you envision that this information, which we'll see in a while in the full presentation, might change that?
Well, what a fascinating area that's really blossomed over the last few years, right? I mean, here's this kind of rare convergence where something that's more convenient for the patient is actually clinically useful, and actually, I wouldn't say replaces, but complements kind of tumor biopsies, physical tumor biopsies. This idea of sampling the entire burden of tumor metastatic disease, I think, is interesting and maybe captures a different part of how the tumor is growing and evolving over time. So this kind of evolution from using it, I think we all kind of cut our teeth using it in the EGFR story, where we were using liquid biopsies often at the point of progression on erlotinib to decide whether they have T790M to move on to osimertinib. But it kind of got it in the clinic, got us using it. And now I think moving it to the first line, I've generally used it in a couple of ways. One is certainly where patients are not well enough to undergo a physical biopsy. Their lung tumors in a place that's inconvenient to get to or dangerous to get to, or the first one just didn't yield enough tissue to make the diagnosis. But I think the kind of data that Dr. Papa is going to present is provocative. And I think if we really did have comfort that these liquid biopsies were going to catch as well as a tumor biopsy the information we need, I think that's very compelling. I'll be looking for the finer points. Are we catching just the point mutations? Are we catching some of the fusions that have become more important in lung cancer, like ALK, like NTRK, for example? I'll be curious to see the finer points there. But I've kind of been using them kind of complementary to my tumor biopsies. Mm-hmm. And definitely there are patients where I send the liquid biopsy, schedule the tumor biopsy, and know that's going to take a week and a half to schedule anyway. If I have the liquid biopsy in hand by that point that it's scheduled, then I get to cancel the tumor biopsy. And if not, then I'm set to go on that front. Right. But I do recognize that I'm getting leery of how insurance will cover these. And I sign the requisitions always with kind of a question of, I sure hope the patient doesn't get some pushback from insurance, because these aren't inexpensive tests.
Well, if the sensitivity gets good enough, then it could arguably become a real substitute. We'll need to see how this evolves. Right. But I think that this plasma NGS space has been evolving and improving very quickly. Mm-hmm, so it's not far-fetched to envision doing that.
Right.
And just to clarify, this is going to be Dr. Vali Papadimitrokopoulou, who's presenting at AACR, and we'll see what those data show. But one of the advantages that's also cited is the turnaround time, which of course is a real-world issue, and you allude to this, that you get the plasma-based data, in this case from Guardant, in just over a week or around a week. It's not much more, and it's more than a week longer to get the results back with tissue, and you have to schedule the time for the biopsy, get the tissue out from the pathology lab, which often has some delay to it. So the actual time to see a potentially actionable result may be 2 weeks earlier.
Right. And to speak nothing of the iatrogenesis, biopsies still cause problems. And again, not often, but we do get the pneumothoraces, we do get bleeding. So sure. I think, and again, even from the scientific point of view, this idea that it's actually maybe beneficial to be sampling the entire tumor burden and not just the one that you happen to be able to put a needle in logistically.
And I think that as big a boon as this may be for academic centers, I think the bigger improvement, or the bigger change, may be in the community-based centers, where I think that there's been a lag in the testing rates because there often isn't as much tissue. There's more challenges in getting a biopsy done and sent out. Right. And if you lower that barrier, and you can now order a plasma-based test from the clinic lab where you're practicing and seeing the patient that day and getting a result back in a week and a half, that's really going to potentially lead to a lot more patients getting molecular testing who might not have had that done just because it was a much bigger barrier.
No, I agree. It really, I think, could change the uptake in this kind of broader genetic testing. And you've written eloquently about kind of, are we ready for that really broad panel NGS, and are we ready to reckon with the data that comes back? But as we kind of get to that critical mass where there are enough mutations and alterations that we can treat in the front line or get on readily accessible trials, it certainly becomes more compelling that, again, whether the academic medical center or the general oncologist can order this and get the results quickly. I do think that part of the onus on us in academia and on these companies, though, is to make sure that the product that comes out is readily understandable by that very, very busy general medical oncologist who doesn't have his or her hands right in thoracic oncology. I think there's a lot of garbage in some of these reports that we get from the likes of Guardant and Foundation, and hope there's a better curation of those reports over time.
I totally agree. And for the record, even though I have been on the more judicious side about adoption of broad-based testing,
fair enough.
I think that certainly in a setting like advanced non-small cell, we're now at that critical mass or tipping point where it makes sense if you're going to be needing to look for 5, 6, 8 different markers. It makes sense to look for the whole panel. And the thing that's so interesting and exciting is that the more testing you do, it's just going to exponentially increase the insights about it. It makes it a lot easier to do trials of patients with RET fusions or MET exon 14 skipping or other rare settings that have been very challenging to study. So the more you look for, the more you find, basically.
Exactly.
What about in the setting of serial testing? Do you see that being used? Are you tempted to do it? Do you think that in 3 or 5 years that's going to be a routine way to assess response?
I can envision that. I think we're already doing it in a research setting. We happen to have a protocol where we do liquid biopsies on EGFR patients at every imaging point, just for the idea to see, can we see early evolution of the resistance mutations that develop. But I think it's interesting research. Is it ready for prime time in the sense that it will direct therapy in the clinic? I'm not sure it is. I think the next kind of big push might be in the ALK setting, where when we see resistance on our initial choice of a TKI and ALK, can we determine the resistance mutation and maybe eventually do precision oncology to choose the right next line of therapy. We're not there yet, and for all the times we've talked about it in talks on the podium, I'm not sure that those very lab-based data are quite ready to be used out in the clinic. But I can envision a day 3 to 5 years from now where we really can use a very quality liquid biopsy and to answer which of the many drugs on our menu might be the right thing, or the right combination of drugs, which I think is probably where we're going in some of the targeted therapy spaces.
And have early feedback about what's working or not working,
exactly.
and modify accordingly.
But I also want to be really cognizant of, even though maybe it will be more cost effective ultimately to do liquid biopsies instead of repeat biopsies that cost $10,000 and a testing that costs $5,000, I'm not sure that it's yet ready for prime time to say this very expensive test serially is going to be useful, except maybe at the points of progression.
And
but
I think we're
see it evolving.
We're going to need to see if that translates to better survival outcomes.
Exactly. And I think we have to hold our sponsors to that threshold and really prove that that use of technology is useful.
Let's turn to the personal side. You're a relatively new dad. Congratulations.
Thank you.
And you were on paternity leave for a while, so great. How was that, and how was that decision of putting things on pause? Did you get resistance from the institution or colleagues? Because I imagine that if your institution's like many others, there's not a lot of easy room to absorb a loss. I mean, even if it was a scheduled and temporary one. So can you talk about that?
Yeah, isn't it amazing how, I chat with my dad, who I think took exactly 2 days off and had to be back at work on Monday, how these days at least it's in the conversation in the workplace about the rule for family-friendly policies.
Right.
I work at a very liberal city, San Francisco, for a very liberal institution, the University of California, and actually until last fiscal year, the paternity leave was only 2 weeks long. And so it happened that my kid was born right after the change was to 4 weeks, but I kind of wanted more time. And luckily with my administration, and I was able to use my vacation time, but also really have the support from my division to say, take the time you need for your family. And I feel like that's one nice thing about working in a place like I do, that wasn't glanced askance at all upon. I'm not sure that's true at every university or certainly every company these days. So I was very fortunate in that. It helps that we're a group where I had some people to take over my clinic, and the timing worked out well. But it was good that the initial response from my division was, do what you have to do, enjoy your time off. We look forward to seeing you when you come back.
No, that's great. I think, as you allude to, I think that is not the easiest thing. And certainly many places couldn't absorb the loss of somebody. As we talk about the increasing subspecialization, that also means that somebody who's primarily a GI person can't easily step in and do your job, or you cover for them as easily. So these are some of the evolving challenges we face as oncology becomes so increasingly complex.
Definitely. And I still have colleagues who had kids about the same time I did who only took their 2 weeks off, not at UCSF, but across the country, either because that's all they were given or that's all they felt they could, from a career point of view or from a team point of view, afford to take off. And I think that's too bad, especially when some of the research about early time with your kid comes out of our academic medical centers. It's ironic that the academic medical centers don't give that time off more readily than they ought to.
Well, fortunately, you won't have to worry about any more things. For the kid's all set now and doesn't need any more
I wish.
Almost sleeping through the night.
I don't know. Residency felt hard. I think this might be harder. I'm also 20 years past that, so it's hard to pull all-nighters when you're 43. But he's pretty cute, so it makes it a little easier to wake up in the middle of the night.
Well, congratulations, and thanks for taking the time today. Really appreciate it.
Always fun.
Thanks so much for joining me today for this West Wind podcast. We hope you'll be interested enough to subscribe either by checking out the options at beaconmedic.com or looking for West Wind Podcast on iTunes or wherever you find your audio content. Please take the time to submit a review, and we'd also welcome your feedback at westwindpodcast@gmail.com. Until next time, this is Dr. Jack West. Thanks for listening.